Welcome to you all. Today I will talk about one of the very important topics in the field of basic linear endoscopic ultrasound, which is linear EUS examination of the liver, the normal anatomy and the pathology. My agenda today will include introduction, segmental liver anatomy, linear EUS examination of the normal liver, and the clinical implications of segmental liver anatomy. EUS allows for the accurate evaluation of liver anatomy and related pathologies, especially the left lobe. Moreover, EUS assessment has proved more accurate in detecting small focal liver lesions missed by standard imaging techniques such as CT and MRI. The evolution of EUS-guided interventional techniques such as hepaticogastrostomy, ablation of tumors, and measurement of portal pressure gradient has attributed to the increasing importance of understanding the hepatic segmental anatomy during the EUS examination. This is the segmental liver anatomy. The liver is divided into 8 segments: right and left lobes, divided by the middle hepatic vein. The left hepatic vein divides the left lobe into medial segment, which is segment 4A and B, and lateral segment, which is segment 2 above and segment 3 below. And the right hepatic vein divides the right lobe into 2 segments: anterior segment, which contains segment 8 above and segment 5 below, and the posterior segment, which contains segment 7 above and segment 6 below. In our review article in the Endoscopic Ultrasound Journal last year, we suggested a rather simple, practical approach to linear EUS examination of the liver. We start the examination by locating the echo endoscope at the cardia and gentle clockwise and anti-clockwise rotation to search for our landmark, which is the inferior vena cava and the right hepatic vein. This is the intrahepatic portion of inferior vena cava, and this is the right hepatic vein. The right hepatic vein has widest diameter at its insertion with the inferior vena cava, with gradual sloping, gradual decrease in diameter as it is going deep in the liver. Here we can identify 3 distinct segments. Segment 1, which is the caudate lobe, in between the echo endoscope and the intrahepatic portion of the IVC, and segment 8, in between the IVC and the right hepatic vein, and part of segment 7 deep to the right hepatic vein. Then we will do gradual, slow anti-clockwise rotation. Anti-clockwise rotation to locate the middle hepatic vein. The middle hepatic vein is a long vein and have a homogeneous diameter throughout its course. And here also we can identify an important structure, this whitish ligament, which is the ligamentum venosum, communicating the inferior vena cava with the left portal vein. Here we can identify 3 important segments. Segment 1 is also the caudate lobe in between the echo endoscope and the ligamentum venosum, and segment 4A in between the ligamentum venosum and the middle hepatic vein, and segment 8 deep to the middle hepatic vein. Then we will continue slow, gradual, anti-clockwise rotation to locate the left hepatic vein. Here we can identify segment 2 above and segment 3 below. Here in segment 2, it is about 40 to 45 centimeter from the cardia, just below the cardia. We can do biliary drainage, especially the rendezvous technique and the antegrade insertion of stent, because in this segment, segment 2, just below the cardia, the left hepatic duct is more in line with the common hepatic and the common bile duct. So this segment here, segment 2, just below the cardia, is suitable for rendezvous technique and the antegrade stenting of the left biliary system. Then let us continue examination of the liver from the stomach. This is the middle hepatic vein. We locate the ligamentum venosum, which I told you before. This is the ligamentum venosum communicating the IVC with the left portal vein. And then we push the echo endoscope forward some centimeters to locate the umbilical portion of the left portal vein. This is the fish eye appearance, the classic fish eye appearance, which is the umbilical portion of the left portal vein. And then we push the echo endoscope a little bit forward to locate another ligament at the umbilical portion of the left hepatic vein. This is the ligamentum teres. So this is the ligamentum venosum to the right of the screen and ligamentum teres to the left of the screen. So this is the ligamentum teres. Here we can identify two important segments, which is segment 3 also above the ligamentum teres and segment 4b below the ligamentum teres. Here in this segment 3 we can do biliary drainage. Best is in cases of hepatico-gastrostomy. Hepatico-gastrostomy, because the stent here will be more stable. And here the distance is below the cardia by about 5 centimeters, so it is about 45 centimeters from the dental arch. So it is below the cardia by about 5 or more centimeters. So the stent will be away from the cardia, so there is no irritation at the level of the cardia. So here is best for segment 3 here. 45 centimeters from the dental arch is best for hepatico-gastrostomy, while as I told you before, about 40 centimeters or 41 or 2 centimeters just below the cardia in segment 2, it is best for rendezvous or antegrade stenting. Okay, so this is segment 3 and this is segment 4b, and this is the fish eye appearance, the umbilical portion of the left portal vein. So again, this is the classic picture which I told you before, very important when you start to do hepatico-gastrostomy and biliary drainage. So this is examination from the stomach. We examined most of the all or even all the left lobe segments, segment 1, 2, 3, 4, and some of the right lobe segments, but the rest of the right lobe should be examined from the duodenum, from the duodenal bulb. Here this is the echo endoscope. We push the tip of the echo endoscope located in the bulb and push it gradually and very gently, very gently against the superior duodenal angle. So the echo endoscope will take the J-shape pattern. So this is the echo endoscope J-shaped located in the bulb of the duodenum, and then we will start do very gentle counter-clockwise rotation or anti-clockwise rotation in this position. In this position we can see the portal vein. This is the main portal vein, very nicely seen. We keep a slow and very gentle counterclockwise rotation. So the portal vein will divide into its two main branches. The left portal vein is going down with the screen, and the right portal vein will go up and to the left side of the screen. So this is the left portal, and here this is the right portal vein. We will keep counterclockwise rotation. The right portal vein will divide into its two main branches, the right anterior branch and right posterior branch which separates segment 6 above and segment 7 below. Segment 5 in between the echo endoscope and the right anterior branch, and segment 8 below, and here segment 6 and segment 7. So this is 5, 6, 7, 8, or 5 and 8 and 6 and 7. Okay. Then we will go to the second part of the duodenum, locate the papilla at the medial aspect of the second medial wall of the part of the duodenum, and then we do clockwise rotation 180 degree to look at the lateral wall. When we look at the lateral wall of the mid-second part of the duodenum, we can see the right kidney, and here the part of the liver related to the right kidney is the segment 6. So I can see segment 6 only also from the second part of the duodenum. We can see segment 6 also from the second part of the duodenum. So let us see the clinical implications of the normal segmental anatomy by linear EUS examination. Diagnostic, of course, as I told you before, we can detect small focal hepatic lesions not seen by CT or MRI. When we see a focal lesion, we can do real-time elastography, contrast-enhanced endoscopic ultrasound, and EUS. Of course, we can do EUS FNA or FNB. Also, it has therapeutic implications, which is EUS-guided liver tumor ablation, EUS-guided selective portal vein embolization, EUS-guided ablation, EUS-guided liver abscess drainage, and EUS-guided biliary drainage, as I told you before. From segment 2, we can do rendezvous technique and antegrade stenting, and from segment 3, 45 centimeter from the dental arch, we can do hepaticogastrostomy. Let us talk in some details about the very important task of EUS is its role in detecting occult liver metastasis not seen by CT or MRI. Multi-detector CT and dynamic MRI are the most widely available and acceptable non-invasive modality for detection of liver metastasis. However, they have a limited ability to detect hepatic lesions smaller than 1 centimeter. The detection of an occult liver metastasis could have a major impact on staging of malignancy and changing the management plan. For tumor size more than 2 centimeter, multi-detector CT has a sensitivity of more than 90% in detection of these rather large lesions, and also MRI, while lesions smaller than 1 centimeter, the sensitivity of CT and MRI will decrease significantly to less than 40% and less than 30%. We did a prospective large study in our unit over 5 years in the sensitivity of endoscopic ultrasound in detection of small liver metastasis not seen by CT. Our cases are primary tumors, whether in the pancreas in most cases, or gastric tumors, cholangiocarcinoma, papillary lymphoma, and so on. And all these cases, 730 patients, we examined the liver thoroughly and meticulously, searching for small metastasis. Out of the 730 patients, we found that 124 patients had liver metastasis. 76 of them can be seen by both endoscopic ultrasound and CT or MRI. Endoscopic ultrasound missed only 6 cases out of the 730 patients. We missed only 6 cases, by endoscopic ultrasound, while these cases were detected by CT and MRI. While CT and MRI missed 42 cases not seen by CT and seen by endoscopic ultrasound. The median transverse longitudinal diameter of the cases, of the 42 cases missed by CT or MRI, were 12 by 15 millimeter. And 15 metastatic masses were smaller than 100 millimeter. All were seen by endoscopic ultrasound and proved malignant by EUS FNA. The 6 cases missed by endoscopic ultrasound were located in the right lobe of the liver, segment 5 in 3 cases, segment 6 in 2 cases, and segment 7 in 1 case. And the median diameter was not small. It is about 16 by 20 millimeters. So what I would like to say, that CT and MRI usually misses small lesions, smaller than 1 centimeter, while endoscopic ultrasound usually misses lesions located in the right lobe. So both are complementary. So both techniques are complementary, EUS and CT and MRI. This work was published in endoscopic ultrasound last year, fortunately in the top-ranked endoscopic ultrasound. This is one of our cases with pancreatic body adenocarcinoma, and during the examination of the liver we found a very small hepatic focal lesion. Was not reported by triphasic spiral CT. This lesion was about 4 by 5 millimeter, very small focal lesion. Of course, the plan of management of the patient was changed from radical surgery to radical surgery and segmentectomy, surgical resection of this small focal lesion of the liver, and we may do radiofrequency ablation or alcohol injection intraoperatively or preoperatively. Here we can use the elastography and very nicely seen that it is blue in color, so it is firm. This confirming that it is, or favoring the possibility of metastatic lesion. It is well defined, circumscribed, and hypoechoic. And of course here we can do EUS FNA of any hepatic focal lesion, EUS guided. It is very easy, very safe, because the liver is well seen by endoscopic ultrasound. It is near to the probe, so we can do FNA safely and very nicely, and no complication encountered during EUS FNA or FNB from this hepatic focal lesion. So we can do it very easy. Also, this lesion is rather away from the echo endoscope, but it's very nicely and very easy and very safely we can do FNA from the liver. So my take-home messages are: thorough and meticulous examination of all liver segments is mandatory, especially in staging of pancreatic, GI, and lung malignant lesion to detect occult liver metastatic lesions not seen by CT or MRI. Liver segments are examined from the stomach and the duodenum, and try to identify the landmarks of each anatomical region, as I mentioned before. Thanks to Dr. Amr Abulmagd and Dr. Katarzyna Paulak from Poland for providing me with these nice schematic pictures. And thank you for your attention.